at the Maritime Spore Support Unit, and I'm acting as your host this afternoon. I'm sure you're used to seeing Rachel Giacomontonio's face if you've come to these sessions before. Rachel's away, so I'm hosting today. So if you're not familiar with the MSSU, we're one of 11 SPORE support units across Canada that support and conduct patient-oriented research, and we work across all 3 maritime provinces. I'd like to start by offering a land acknowledgement that reflects my location here in Jabukduk or Halifax. And if you can go to the next, I can go to the next slide there. I forgot I had control. Thanks, Andrea. So I'd like to begin by acknowledging that we're in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the treaties of peace and friendship, which the Mi'kmaq and Wolastoqiyik people first signed with the British Crown in 1725. We are all treaty people. We also recognize the histories, contributions, and legacies of the African Nova Scotian people, which have been here for the last 400 years. Many of you are joining from other parts of the country, so I'd like you to add a land acknowledgement or mention that in the chat, sharing the lands that you live and learn. So before we dive in, a few housekeeping notes. I think everyone's used to most of these by now, but there's always a rogue mic that gets left on from time to time. So just to remind you of those notes, so we are going to be recording the session. We do put these up on our YouTube channel afterwards, which are a great resource. I've rewatched a few of them from time to time. We do have closed captions available if you'd like to use or enable that option. And we will be able to ask questions in the chat. Feel free to include your name, or if you'd like to ask the question yourself. We have a fairly good sized group today, but I think we're small enough that we can, say hello and put our cameras on and chat. If we'd prefer to go that route, just let us know so we can allow you to do that. I think I've covered all of those bits and pieces. The other thing I just wanted to mention is we're still using Zoom today as we have for the other sessions. We'll be moving to another platform in the future. We've been having some Zoom issues lately. I'm hopeful that it will be a lucky day and we won't have any issues. But in case we do, if the meeting gets cut off at some point, just rejoin the session, but it will be sudden if it does happen. That's happened to us in a few previous meetings. So I think we'll be okay, but just again, if anything happens, please just rejoin the meeting and we can resume the conversation. So I'm very pleased to welcome you today to the latest Learning Health Systems in Action webinar. The term learning health systems, you've probably started to hear a lot more about. Certainly in the last year, I've heard it in a lot of places. It might be new or confusing to some people though. So I wanted to just open with a quick definition. So what do we mean by learning health systems? So this definition here is one from the Agency for Healthcare Research and Quality. So in a learning health system, data and experience are integrated with evidence and knowledge that's put into practice. So that might sound like what should be happening, but it doesn't always happen. So when this does happen, patients get higher quality, safer, more efficient care, and healthcare delivery organizations become better places to work. That's the goal. But there's no single definition or model. In fact, I think the number of models and definitions continues to grow right now as there's more focus on this. But I think it has and is becoming clearer over time. So hopefully you're also kind of feeling that as well if you've been kind of engaged in some of that literature or work that's happening. So while there's no single definition, learning health systems are a way of improving healthcare, learning from data, getting evidence in real time, and then repeating that cycle so we can apply that evidence to make changes. So as a result of learning health systems, they're often visualized as a learning cycle. So this is the MSSU's learning health system graphic that we've developed. And it served as a way to both inform people that we work with, but also for our own purposes to kind of center our work around these different core elements. So you can see how the different components in the structure feed into each other. So for the MSSU and for everyone it should be, but is not always, community is really at the heart of the learning health system. So making sure that patients and the community are involved in the work that's happening and the changes and informing informing those changes in the health system. But it's also about using that knowledge, informing policy and practice, collecting that data as we talked about, and again, repeating that cycle over time. Um, so it's a very flexible model. So the approach could be used by a health authority, networks of facilities, even a hospital or a specific unit. So it's very adaptable in that way, but it's really just all about this concept of continuous kind of learning and practice change. So that's what this series is all about. We started this series with a focus on kind of the premise of learning health systems, and over time we've moved into more real life examples of how people are applying this model in practice. So for today's session, we're zooming on one element of this learning health system model. And again, given the presentation title, I think you've probably guessed what that already is, but we're really focusing on this policy and practice piece and how that's informing, again, part of this cycle here. So I'm going to keep the introductions short just to keep as much time as we can for the presentations and then our question period that follows. So I wanted to formally welcome our two speakers from the Nova Scotia College of Pharmacists, or NSCP. Again, we say we don't like acronyms, but it becomes a lot easier to say these long terms when we use them. So we have Dr. Andrea Bishop here with us, who's the Director of Research and Engagement, and also Eric Coates, who is the Director of Professional Services. So they're going to talk to us today about NSCP's evidence-driven approach to policymaking, including organizational resources and strategies needed to support this work. And they're going to illustrate how this comes together in practice with the Staffing and Workload Initiative for Safety and Effectiveness, or again, acronym StaffWise, which is a great acronym. So we're going to do all of that in about 30 minutes or so, and then it should give us lots of time for Q&A at the end. So without further ado, I'll hand things over to the speakers so they can get us started. And I believe, Andrea, you have the mic.
Wonderful. Thank you. And thanks to everybody that's joining us today for sharing their lunch hour with us. Hoping it will prove to be an interesting topic and looking forward to some discussion at the end. So yeah, we're going to be talking about a little bit of the NSCP's journey over the last 6 years or so, and using one of our projects to illustrate how we are I think using many of the principles of a learning health system in our organization. And then I will pass the baton over to Eric, and he's going to walk us through kind of how we're using data in a more practical policy forward approach, and how that's actually continuing that learning cycle for us as well. So in case you don't know us, we are the Nova Scotia College of Pharmacists. We do not educate people, but we are the provincial regulator. So we have oversight and governance of the practice of pharmacy throughout the province. And that includes both the practitioners, the pharmacists and pharmacy technicians, students and interns, as well as the community pharmacies where they work. We work solely on behalf of the public. And so that makes us a great candidate to be a learning health system because our focus is always on patient outcomes. So I wanted to start first with probably the direction we're all most used to, which is how do we actually embed evidence into policy? And then we'll move into actually how does policy drive evidence as well? So I'd like to say that this is traditionally how we have done policy making way, way, way back in the past, but it's probably in the very near past that we were still doing policy development using this kind of typical process. And while I think the argument could be made that evidence can be used at any step of the process, it wasn't really ever spelled out, and it often is very closed-looped. And so, about a decade ago, we started to wise up to this a little bit. Knowledge translation and implementation science really gained a lot of momentum. And frameworks started to emerge, such as the knowledge to action framework that I'm showing right now, that really began to underscore the importance of using that evidence within the policymaking or practice change framework. However, you'll notice that it's fairly separated, so knowledge is still in the middle, and then we go into a cycle, versus what we're really trying to achieve now is that iterative approach, that we're constantly feeding data in, and also the acknowledgement that there isn't kind of that separate knowledge production process. It's all part and parcel of how we're all learning together, and really underscores the importance of us engaging across policymaking and decision making in academia, and also really understanding what is the knowledge and research that's actually being produced within the policymaking realm itself. And so at the NSCP, at the start of the journey, it was really kind of understanding kind of how have we gotten to this place where it feels like it's so difficult to actually get evidence into practice or into policy. And some of the learnings that we've had is that knowledge translation is a very academic term. It does not mean a whole heck of a lot to policymakers. It's not really within that shared language that we might have across those boundaries. And if we think back to that knowledge to action framework where it's at the center, it's really predicated on a belief that there's a knowledge producer and a knowledge user. Whereas it really should be kind of that constant interactive, iterative relationship with one another of we're all producing knowledge and we're all using that knowledge as well. Also, that researcher is not a restricted title. So there's research and there are researchers everywhere across the entire healthcare system. And so really making sure that we take that approach that we should learn with and from everyone. Particularly I think from that policymaker lens that every little bit of evidence actually is important and can be useful. One of my big lessons, so I came from academia, went into policymaking, so have worn a couple of hats, which I think provides a pretty unique perspective. But policymaking isn't linear, and it's also incredibly fast. And so if we think about how are we actually going to start using evidence, producing evidence that's going to align with that policymaking process, it needs to look a little bit different. Underscoring all of this, and I've kind of alluded to this as well already, are we talking that same language and really making sure that that relationship building is foundational to getting evidence and policy driving evidence? It's really difficult. We talk two very different languages sometimes as policymakers and researchers. And so how can we actually learn what the realities of each other's lives day to day are looking, and how can we develop that shared language with one another? And that's really been a particular focus of the NSCP over the last few years. And so what we've been doing here to try to bridge that gap is taking kind of a multi-factor approach and seeing what sticks and what doesn't. But we've had definitely some lessons that have been very helpful that hopefully might be helpful to share today. So I was lucky enough to join 6 years ago as an embedded researcher, and I think that that has been incredibly helpful to have that embedded research knowledge on the team and to be that individual that can be bilingual across the organization, and then working with lots of pharmacy practice researchers. A few of them are on the call today, and also working incredibly close with the MSSU over the last few years as well. We have taken the stance that within our organizational budgeting that we also do develop small funding opportunities. So granting opportunities these days are incredibly challenging, as we all know. And so really making sure that we're investing in policy relevant research and providing some of that kind of foundational seed money to get some of that research going. We've really developed our policy and program evaluation across the organization. and have involved external researchers in that as well. So really having some of those priority setting exercises with researchers and having that constant two-way communication of what is going to be mutually beneficial for both of us. One of the most interesting things I think we've done is actually create a regulatory sandbox. And so we've created opportunities within our existing policies. So, in particular, our standards of practice, which govern the practice of pharmacy practitioners, to actually be able to do research, to be able to expand scope within a research or pilot protocol, so that we actually have that real world, pragmatic evidence that we need to see if this is a scope of practice or a practice change that we should then more fully enable across the entire profession. And we've also been conducting our own primary research. And that's actually the segue to start talking about staff-wise, but really understanding that there is significant amount of research that we can be doing internally as an organization, and making sure that we bring other practice researchers into that as well. So with staff-wise, it's a really great opportunity to talk about policy-driven evidence. And so I know that we usually talk about how do we do evidence-based policymaking or evidence-informed policymaking, but there's a flip side to that as well, where we actually have policies in place and actually need some evidence, whether or not that's for evaluation and monitoring, or in our constant quality improvement of what policy should actually look like. So it kind of completes that entire loop. So StaffWise is our staffing and workload initiative for safety and effectiveness. And I've just flipped up kind of the full timeline of this work. And as you can see, it's been about a 6-year journey, and it has really been an incredible effort by the organization to ensure that we have the data that we need to make the right decision at the end of the day. So this is really what fulsome policy making can actually look like when we bring evidence into the mix. This work actually began because about 20 years ago, we had a regulatory change in Nova Scotia that required that pharmacies had a staffing plan commensurate with patient care needs. In the ensuing 20 years, we actually haven't had the data that we've needed to even enforce that regulatory requirement. And about 10 years ago or so, we started to get increasing reports of pharmacist workload pressures, burnout, and subsequent impacts on patient care. And in 2018, as part of a new strategic plan, we really had a new focus to make sure that the NSEP as the regulator was having a positive impact on practice environment concerns that were being raised. So the first step that we took is that we actually needed to know if there was a role for us. And so while we actually did have that regulatory requirement, 10 years ago, it would have felt that that might have been an overreaching position for the regulator to be in, to actually start to look at that practice environment. And it would have been the prevailing attitude that staffing levels would have been a workplace practice and something that would have been addressed by a pharmacy owner. But knowing that it was starting to actually impact patient safety and patient care, we embarked on some preliminary research, which included literature review, some structured practitioner interviews, as well as a more fulsome validation survey, and some interviews with key sector players to really understand what was happening in Nova Scotia and Canada and internationally. So we could get a better picture of how practitioner workplace conditions as well as practitioner burnout was actually leading to patient safety issues. And the great news from this preliminary research is that we did actually establish what we needed to say that the NSEP had a regulatory role in addressing this. We saw that there was an imbalance between demands on pharmacy professionals and the HR capacity to do it. And most importantly, we were able to establish through the evidence already collected in the literature that there actually is a linkage between professional burnout and risks to patient safety. So this meant that we were fully in the game. We found these two key findings, but we also found many other things through this process. And this really highlighted for us the complexity of the issue. And I just want to pause on that for a second because I think it's really important when we're thinking about how we use evidence within policy that we're really taking the time to better understand the complexity of an issue and to really identify what the problem is rather than selecting something quickly and moving forward with it. And so that preliminary research gave us a whole wealth of ideas of what might actually be leading to this imbalance and what were the outcomes of that imbalance as well. And so knowing that we're one organization and can't address all of the issues within a wicked problem, like pharmacy practice environment concerns, we then undertook a really structured approach to how we were going to prioritize our efforts. So we brought in external stakeholders on a strategic planning advisory group and undertook an exercise where we looked at impact and feasibility. And what came out of that work was a new prioritized focus to ensure that pharmacies have the staffing required to consistently deliver quality services in a way that can be sustained by pharmacy practitioners. And the importance of that focus, too, is that it really linked nicely back to our strategic plan and the ability to also enforce that regulatory requirement for appropriate staffing levels. So once we had that prioritized focus, we spent a lot of time understanding what has been done, what has worked, what has not worked in other sectors, and also really starting to build out what our data collection plan could look like. And the reason we spent a lot of time here was that we knew that we needed very robust data collection. And we also needed data collection in a way that we could have unique information for each pharmacy in Nova Scotia. And it really underscored the necessity for us to have data that could not be refuted, data where somebody could say, yeah, but that's not me. And to really bring the strength of as much evidence that we could collect as possible to whatever regulatory intervention we were going to do. That led us to better understanding that we needed data collection across 4 constructs. So looking at the total staffing for each pharmacy, looking at the workload for each pharmacy, and providing some more contextual data around the quality of care that was being provided at each pharmacy, and that was at the practitioner level, as well as going out for a public survey, and also better understanding well-being at the practitioner level as well. And so what we were trying to achieve with data collection across those 4 constructs was to understand if we could replicate what we had found in that preliminary research and in the literature about the linkages between pharmacy practice environment and staffing and quality and well-being, if we could replicate that here in Nova Scotia. Data collection took about a year, and we collected over 1 million data points, which was significantly more than we had bargained for, I think, at the beginning of this journey, but was really exciting to see this come and take shape over the course of a year. You'll see that we collected data from a number of different data sources and across all of those constructs. This included data requests from the province, looking at both the drug information system, Can Immunize, as well as pharmacare billing. We collected data from owner groups to better understand whether or not that data was comparable to what we could get at the provincial level. We collected data from every pharmacy manager in Nova Scotia that looked at staffing and use of technology, characteristics about what their dispensing looked like. We also collected data from almost 500 practitioners, and that was looking at self-reported quality and well-being. We launched our first public quality survey that included patient-reported experience measures to better understand how um, public perceptions of quality potentially differed from practitioner perceptions of quality. And we also took time to really look at workload, time, and intensity. So while we had all of those dispenses from our drug information system, providing additional context on what are the nuances between complex prescriptions, etc. And in our initial data collection, you'll see that there's some primary data sources as well as secondary or validation data sources. So because this was our first time doing it, really making sure that we collected data from a number of different sources so that we could validate it across all of them, and really feel confident that we had the full picture at the end of the day. So I'm going to throw it over to Eric, and he's going to walk us through how we took all of this data and transformed it in a way that was actually practical to use for policymaking.
Thanks, Andrea. I'll just clarify a couple points before I get going. First, as the Director of Professional Services, people often think that's like a finance and HR role. I am responsible for quality assurance in community pharmacy, which is where I come in. And also want to point out that this is specific to community pharmacy. There's often a bit of confusion about whether or not hospital pharmacies are involved in any of this work. And currently, based on the legislation, we do not regulate the practice of pharmacy in hospital. So for context, this is community specific. So yeah, all this boils down to this staffing score, which looks very simplistic on its face, but as Andrea's kind of already pointed out, there's a lot going into this staffing score. But ultimately, it gives you a ratio of the available time, available staff to complete the workload, represented in time, and then the total workload demand, which is from those million data points that we've gotten from various sources. So just to give you a little bit of an idea of what that looks like under the hood of that equation, is this huge amount of data. On the left side in the darker blue, we collect that from our registrants during the renewal period every year. And then on the right side in the lighter blue, we get that data from a few different sources in partnership with government. And I just pause here to say one of the key enablers of being able to do this well has been our strong partnerships with the Pharmacy Association and government to have everybody kind of working together to bring this data to us in a timely and meaningful way so we can actually work with it. Were it not for those partnerships, we would be kind of sunk on this. So that's been great. But yeah, just to give you a kind of a sense of how big this is, I personally can't open the spreadsheet on my computer without crashing it. We have other people who do that for us and kind of summarize it, which is great. So yeah, as Andrea said earlier, we did have a bunch of different data sources in the initial um, information gathering. But at the end of the day, this quality score was a key factor in helping us understand that this made sense, that there was an actual correlation to the self-reported overall quality, the patient reported experience measures, all that stuff did correlate in the end to poorer outcomes, poorer experience, et cetera, when staffing was lower, based on our model. And then similarly under well-being on the practitioner side, there was a correlation there that gave us confidence to sort of test our model and understand that indeed the scores do reflect reality. And I should pause there just to say there's always a little bit of an exception. Not everybody is a number, obviously. Some people are incredibly talented, skilled practitioners who thrive in busy, chaotic pharmacies. But to smooth that out and compare across all pharmacies, this does seem to hold true. Sorry, slide here. Yeah, so this is as I was saying, this going from anecdote to evidence from the things that we've heard and then actually understanding what this all means. We did have a strong relationship between staffing score and well-being, and as well as quality and well-being and quality. We also learned that burnout due to unsustainable workload, reduced standard of care due to unsustainable workload. Those are all very real things. Interestingly, that middle one with the smiley face, we've realized that expanded scope activities. So as you are all, or some of you are probably aware, there's been a very big scope of expansion in Nova Scotia community pharmacy over the last several years, and that actually mitigates burnout, that practitioners enjoy the opportunity to do more and provide better care and provide more care. However, that comes with a caveat that there needs to be time and capacity to do that expanded scope work. And then, yeah, also business targets, increasing stress, etc., are all insights now that we have a good handle on and can really get a look at with our data and with our model. So in reality, how this is coming into actual effect is that we first drafted a policy based on our regulatory requirement of having staffing levels commensurate with patient care needs. And that all sort of points toward having a staffing score that is kind of looking for getting that perfect one of your ratio of workload is meeting exactly your workforce. And so understanding that it could be a really tall order to get to one for everyone. It's the main thing that we're trying to push for is improvement. And to get to that improvement, we're taking a committee-based approach, which is that all pharmacies will receive their staffing score, and the score is not just a number, it's a scorecard that shows them all sorts of data related to pharmacies that are similar to them based on workload and a few other metrics, as well as what their technology use is, what they've reported to us for their staffing. There's quite a few different data points in that scorecard to give them an understanding of the way we see their pharmacy. And so then they're given that score and come to the committee to discuss how that score is working and what their plans are to improve it. And there's 315 pharmacies in Nova Scotia. We're not bringing everyone to the committee. We're taking a risk-based approach to this. And so those that are in the lower scoring staff scores are going to come first and work with the committee to improve. And the idea here is to have collaboration between the NSCP and the pharmacies to seek improvement, not necessarily like coming down on people with a big stick to say, your score is bad and you're in trouble. That's not the approach. It's to work together and the test for compliance is cooperation and collaboration. So we're going to continue to gather data. That's phase 3 of the implementation approach, or ongoing phase, I guess, annually we'll continue to gather data, and we've learned that it's getting one point in time is not necessarily reflective of the current state in pharmacies. So we do part of our approach to the committee process is to validate the data again before we talk to a pharmacy directly to make sure that what we think the current state is accurate. And then ongoing use of that scorecard and helping pharmacies understand what that means. Um, and so that ties it all back to, again, the learning health system. One really cool thing about this is, so like for those of you who are familiar with community pharmacy, there's a lot of corporate oversight of a lot of different pharmacies, which they look at this stuff 10 ways, in every possible angle, best possible efficiencies, et cetera, et cetera. But not necessarily at the individual pharmacy level, and certainly not in the like owner-operated independent pharmacies. So we're pretty excited about the opportunity to be able to give individual pharmacies this kind of enabling tool to look at what they have, and plan accordingly for the sake of better care. Um, And and then finally, my last piece here is that for us, our kind of learning health system approach to this is it's not just about staff wise. As I oversee quality assurance and pharmacy practice here at the NSCP, we have a lot of cool stuff and cool insights that we're going to be able to pull out of this data set going forward. Compounding in a pharmacy, how much of that is happening, and where is it happening, and what needs are being addressed in certain communities as we continue to move forward with this primary care work that's going on with the CPPCC project, for example, which is our primary care, for those who don't know, our primary care community pharmacy project, to help better inform system design and service delivery in partnership with the primary care teams in government here in Nova Scotia. And we can also gain some insights into perhaps those who may not be compliant with the regulations or our standards of practice right now. And we could do pointed inspections based on some of the data we're seeing, et cetera. So that's all been really cool, and we're just starting to get to understand that a little more as we play around with this data set beyond the context of staff-wise. So I think that's it for me. I think we can jump into questions.
Awesome. Thanks to you both. That was a great presentation. I applaud your use of describing all of the data points without getting into the specifics of how that was all collected and how you analyzed it. So it really allowed us to focus on those kind of key messages that you brought forward. We did have a few questions that have already started in the chat, so that's great. So we'll start with those, and then again, just kind of remind people that you're welcome to type in the chat that you'd like to ask a question aloud, or put it directly in the chat, and I will move that forward for you. So we had a question early on to Andrea about how you kind of transferred to policy making and how that all worked.
Sure. Yeah. Well, where do I start? So I have a master's of health admin, so started out thinking I would be a policymaker before I went and did my PhD. And so had that, I guess, background, at least, and foundational knowledge in policymaking, although had never practiced it yet. And had been doing pharmacy practice research since about 2008. And so had actually done research with the college on a number of occasions, and they had a need for a policymaker. And I said, I can do that, but I can also do research for you. Are you interested? And I guess the rest is history. So very fortunate that the NSCP is an organization, and a particular shout out to our CEO and registrar, Bev Zwicker, who really understands the value of evidence and evaluation in the work that we do here.
Thanks, Andrea. Yeah, those questions are always, they always seem to come up when people move from different roles. So it's really helpful to kind of share that experience. And Zanib just commented that they are started on a similar path, but are now in academia. Um, and yeah, I think that also highlights the power of networking, how it's so difficult to do that, but it is kind of interesting how that experience does kind of build on networking and working with different people.
It's all about relationships.
Yeah. So we'll move into the next question that is around sharing the work. So Perry is asking whether the literature review or other components of the preliminary research can be shared to other provinces to consider.
Yes, I think a link to our Staffwise report is going to be sent out with the evaluation. And if anybody's interested in getting the literature review, our email address, the info at, is on the screen right now. If you want to shoot us a quick email, I'd be happy to do that.
Thanks, Andrea. Another question from Zanib, I believe. Oh, yes. Just wondering, I know you spoke a bit about how the learning health system applies to this work. So maybe just kind of reiterating some of those points around how this applies to the work that you did.
Sure. Just gonna I've got the graphic right here. So I'm gonna look at it while I answer the question. So, I mean, research and evaluation obviously is a large component. I mean, Staffwise itself was, I don't think this is an actual term, but I've started using it. It's regulatory research. It's the research that we need to be the regulator and improve our knowledge. We've gained so much knowledge about what's even happening in community pharmacies across Nova Scotia now. We have, as Eric said, a very intense spreadsheet that tells us, who's dispensing what, where is our workforce even across all of the 311 pharmacies that we have right now. What are the ones that might be having a bit more trouble providing the patient care that we need them to, and many other things. There's been even some interesting things that have been in the news lately around business metrics with community pharmacy, where, when that kind of popped up in the media, we actually had answers in Nova Scotia because of the data set that we've built. So we were able to say, yes, business pressures are leading to patient care outcome risks potentially, but not in every pharmacy and not to a significant degree, at least in this province. And so that is, it's massive to have that data at your fingertips when you've got those policy questions that are arising. We're creating practice changes and policy out of that knowledge now. And so we've got a new pharmacy staffing level policy that's now being implemented. Through that implementation, we've got a significant evaluation plan for this first cohort of Staffwise pharmacies. So that's the data that's being generated out of that policy implementation, and that's going to continue to feed back into that loop. So I think that's how we're doing the full circle with the learning health system.
Yeah, absolutely. I liked how you emphasized those different points and where new data would be collected when that would inform new decisions or changes to what you're doing. There's lots of comments happening in the chat, so that's great. Love an active chat. I think one participant commented that it was a great presentation and application, that it applies to the PDSA, so cycle in a policy development context. So again, lots of different kind of frameworks and cycles that speak to this continuous quality improvement piece. So I think they're more similar than different in the end, is a good way to kind of think about those pieces. There's a question from Perry about hearing about the collaboration that's happening in the province. I'm wondering if you could speak more to the data sharing between NSCP and partners, including the Pharmacy Association and the Ministry or Department of Health here. Do you have Do you all have access to the data or restrictions about how it can be used?
Yeah, I can answer that. We do have access to everything. Access can be a little bit difficult at times just due to the actual logistics of getting it. But from a privacy perspective, we do have authority to access it. We also have inspector authority to gather records from any pharmacy that we regulate. So we do have that advantage as well. But yeah, we have access to every bit of dispensing data as well as pharmacy services data and can immunization data. And then we compel pharmacies during the renewal period to provide us the workforce side of things. So yeah, no restrictions other than we found it sometimes a little challenging to get the data in a quick, organized way. But that's getting better as we continue to do this. We've now done it twice, and we think it'll continue to get better uh, over the next cycle.
Aaron, I don't know if you want to touch on too, maybe like how we've shared what we've learned with others.
Yeah. So it's interesting. I mean, it's a private industry and there's a lot of competition. So we have to be careful with what we share and how we share it. So specifically, the scores, et cetera, get shared at the individual pharmacy level, and what they do with it is their business. But as far as what we do, we don't blast this out to everybody. We do meet regularly, though, with different owners groups. The Pharmacy Association's Economics Committee is comprised of a bunch of different owners representatives, and we do speak with them about sort of what it all means, but not into the detail of the actual scores and revealing, what could be seen as competitive advantage type information. We're not in that business at all. We're not in any business. We just try to give them context about what we're trying to do. There's been a little bit of pushback in the initial days of, this is business. This is what we do. Is our business planning is what we do. Strategic planning is what we do, and we've said, well, if you did a good job at that, then we wouldn't be here. There's patient care risks, and that's our mandate, and so that's why we're getting into this project, and so yeah, I guess that's a bit, and we've had a little bit of communication too, I should say, with Department of Health, who is the payer of publicly funded services and dispensing, and so we've weighed in a little bit with them about some of our understanding of how long it takes to do certain activities based on our methodology, which was a little bit different than how they were calculating it. So we have gotten into that a little bit, but again, we haven't shared specific numbers or anything like that. We try to keep our objective public interest separate.
Yeah, great to hear that context and to also speak to those challenges and that rapid access to data as part of the learning health system model, but certainly not just in this context, but in many, it's very difficult to get rapid access to anything. So I guess resonated with your timeline of how long it takes to get these different sources of data, both collecting primary data, accessing secondary data, and then the modeling and all the work that, you didn't go into the details about that likely took a significant amount of time as well.
I will say I am hopeful. Like, I think projects like this start to spell out the need for data nimbleness and accessibility. And so I think like our government partners, I think they see the vision as well. They are trying to make better like cloud-based integrations and things where we can get things more timely and with less labor. So I think we're all headed in that direction, but it is slow. It's big and complex for sure.
Yeah, certainly a lot happening in that space locally and also nationally with a lot of different initiatives and research projects around that. Many more questions coming in the chat, so we'll see what we can get to, but great questions. Sam commented that it was a great presentation, so thank you both for that. So one question for Andrea. So how has the college incentivized embedded research as important in your organization? So speaking to traditional knowledge economies, prioritizing discovery-based academia, and wondering how you kind of overcame that.
Hmm. I don't know that we ever had a grand plan. Honestly, I feel like it was a bit of a leap of faith to get me on board, and it's sort of just baby step and piece by piece kind of come to be a really strong organizational function at this point. Um, so again, had a huge champion in our CEO and registrar. And I mean, one of the things that really incentivized me to make the move was I had a research budget that was given to me every year. So it was no longer having to do the grant cycle or figuring out how we could do the work that we knew that we needed to do. It was, this is, you know, a fiscal priority of the organization as well. And over the years, it's really, I think, just kind of organically grown. Have done quite a few research projects now with MSSU and other pharmacy practice researchers at Dal and building those relationships over the past number of years, and kind of seeing, you know, where does it fit? And it's grown now to, you know, we've got a data-driven performance measurement framework for the entire organization that's now being built out. So it's, you know, I think continuing to demonstrate the value that embedded research brings, the questions that can be answered by it. I think having that understanding that, um, you know, coming from that academic lens of, you know, we're switching towards a more pragmatic approach when we're thinking about policy making. And if folks have kind of had kind of a more traditional relationship with academics, like really starting to build that understanding of this is how academia and policy or decision makers can really truly partner on answering important questions. And it's just been proof of concept and proof of concept. And, you know, it's a well-oiled machine, I think, at this point of research and evaluation. And interested to get Eric's opinion because I'm kind of the one-woman research team here, but
Yeah, I agree with just one other thing I'd add in there is that we've continued to have really good support from our governing council on
yes,
it.
for sure.
You know, as we bring new projects to them, they continue to really appreciate this, you know, it could be a little bit less traditional for a healthcare regulator to be doing this stuff, but then every time we do some new project, Andrea's spearheading, it's always really exciting and it's the most interesting thing to talk about during a council meeting or whatever. So that's been a key thing too.
Yeah.
Yeah.
I think once you start to dangle evidence, people start to expect evidence. And that's the nice cultural shift we've seen as well.
Yeah, that's a great kind of little takeaway of that piece, right? And I think what you didn't talk about that I often kind of hear and experience too is this work still takes time, even in a policy environment. So I'm sure there's lots of, you know, quick things that you're doing that, you know, you can respond to more timely, but this type of large data set takes time to collect, but then, you know, the model that comes out in the end, I think, you know, you're showing all these different inputs that are needed to make this something that's effective and also sustainable. And sustainable requires that continuous data collection because as pharmacists do more, you know, there's more data that needs to be collected and put into that model to refresh kind of what's happening and to capture that. So I think all of the things you spoke to about those enablers, but also the work you're doing is just, yeah, it's really inspiring to kind of see how that all comes together. Another question to Eric, but I think you spoke to this a little bit, so you could just add on anything that you'd like to add to this piece. But Sam also asked about the corporate oversight of community pharmacies and how you manage that. Just commenting that Sam can imagine how they would be very interested in the data set and whether you share it with them or otherwise collaborate.
So yeah, we do, like I'd say, we do give them their individual pharmacy scores and associated scorecards, which have some data on them. We don't give them the whole data set for sure. Um, but it's always interesting in our world to interact with large corporate entities that they basically have the real control over the budget and the whatever business metrics might be in place at the pharmacy level. So interestingly, actually, we're undergoing a large legislation change into the Regulated Health Professions Act here in Nova Scotia. And a piece of that is that the professional accountability for issues at the pharmacy level and now the person who can exert or people who can exert the most control are accountable. So we do have or will have once we're under this new legislation in the summer, hopefully sometime around the summer, will enable us to really hold corporate ownership to account in a new way, whereas kind of previously we've had to hold the pharmacy managers who may not have very much control accountable. So that's it's kind of a new thing that's happening, which is great for us because I mean truly we can't go yelling at somebody who can't fix it, you know. So that'll be good.
Thanks, Eric. And I think we have time for one more question, and I'm gonna just prioritize. There's a couple left in the chat, but a few kind of upvoted on a question about PREMS. So this might be to both of you, but it sounds like maybe to Andrea a little bit more first around if you could elaborate on how PREMS or how community, patient, family engagement influence the development of the scorecard, and drafting of the policy.
Hmm. So not so much the scorecard just yet, but we're working on how to figure that out. But I might give a little bit more context than on, I mean, PREMs are basically the center of everything that we need to be doing as a pharmacy regulator. The patient, the public, is the only reason that we are in existence. And up until a couple of years ago, didn't really have a mechanism to better understand, are we actually fulfilling our mandate to the public? And so starting to go out with that public quality survey was really important. It was great that this project was finally the impetus to collect that really important information. Interestingly enough, a lot of the data came back overwhelmingly glowing. So it wasn't actually particularly helpful to the development of the model just yet. But we are continuing to refine what those primes are actually going to look like. And there are people on this call right now that are on that team that are helping us to actually do that, which is great. And we'll continue to refine and go out with a public quality survey in the years to come with an eye to really figure out how can we better integrate what that public experience is into that model. What can it actually tell us? Unfortunately, the first go around didn't really give us a lot of variation that we could work with. But a really great learning there is that we've got a lot of communications work that we need to do to better prepare the public for what they should expect for high quality pharmacy care.
A unique feature of community pharmacy is that it's so accessible, and in today's health system struggles, let's say, fast and friendly is kind of the the KPI right now, and that exists in pharmacy in spades. So, yeah, good good reviews from everyone.
I like that, Eric. Fast and friendly. That's like sometimes we overcomplicate what's important, but those are probably two of the most important things for sure. So I would like to close the session. Everyone has the contact information for Andrea and Eric if there are additional questions or asks on your end for sharing some of this knowledge. So thanks to you both for a lovely presentation. It was great listening to you, both the presentation and the question period. I learned a lot personally, and I think others have as well. There's just a short link to the evaluation survey that will be sent out after to share your thoughts on the webinar. webinar and any ideas for future presentations. As Andrea mentioned, there'll also be a report shared around the StaffWise project and a link to the recording of the session as well. So thanks so much for joining us, and I hope that you all have a lovely afternoon.
Thanks for having us.
You.
Take care, everyone.